Very good morning to everyone. Thank you, Partho, again for having me here. Uh, I think a job well begun is half done. And counseling is the job which you have to do very well, as my previous speaker said. Once you do a very good counseling, then it's a job which is half done and you don't land into problem. ICL is one surgery. I mean, not just ICL, phakic IOL or refractive surgery. This is one procedure where you have to counsel the patient very well before you take on the patient. And especially for the beginners, my suggestion is to spend the time with the patients in such a way that the patient's questions are answered well. Because you are doing something on a very healthy eye, patient has a good vision, and we don't want to spoil anybody's eye or even have a little bit of complication later on, so that the patient can come back and charge you. So counseling, it's better not left to your counselors. It is best to talk to the patient directly, one-to-one, and answer and keep everything very clear. So this patient came in to me wanting LASIK. This is a refractive error of the patient, right eye and left eye. And we were all ready to take in the patient when we found out the pachy was a little on the thinner side. So we did the anterior chamber depth and started counseling the patient about the ICL. And after the counseling, what we found was the Shermer was 4 and 5. I just have a question for Dr. Partho Biswas. What would you do here?
Divyesh, let's roll it up quickly.
Yeah. So when the Shermer is low, the patient has a dry eye, and as we all know, ocular surface disorders have a bearing on the vision. So even the post-refractive surgery, it's better to clear this up with the patient and then go ahead. Now, Dr. Ramamurthy came up, had shown a beautiful video. He's an expert, and he can do a lot of things. But for the beginners, if the patient has iritis or things like this, it's better to talk to the patient and see whether you want to do it and explain to the patient about the possibilities of cataract and all these things. So it's better to be honest with the patient, be true, and be yourself. It's best not to be greedy. It's better to explain to the patient about the drawbacks of the ICL or the phakic IOL and explain to the patient that there is a possibility of having complications like cataract or complications like endophthalmitis or glaucoma, and then only go ahead. And best thing is you have to believe in yourself and the surgery to convince the patient that this is a good option you can go for. I think the time is very short, but it's best when we counsel the patient properly and explain everything very properly about the complications, advantages, disadvantages, and possible things that a person can have. Then only we can convert this question of getting this patient on the OT table. Partho, I think that's it. I have to finish. We cannot overshoot the time. Thank you very much.